Hello. Patients with hip fracture are admitted to every hospital in the country on a daily basis, and they form a perfect model for the older, frail patient who we look after in the hospital setting. They're easily identifiable. We know who they are from the moment they present. There's not a lot of debate about whether somebody did or didn't have a hip fracture in the way that there would be for somebody who came in with a chest infection or perhaps even a stroke. And they go through a complex pathway of care which takes them through multiple departments and multiple interventions, including surgery and anaesthesia in very old and fragile patients. And the whole rehabilitation, discharge planning, and indeed the community rehabilitation pathway. So they give us a great way of biopsying the care provided by the modern NHS. And they've therefore formed the core for many studies, many pieces of research about the care of older patients in hospital. And topics of nutrition and delirium are something I'll deal with elsewhere. What I want to talk about here is how an understanding of patients with hip fracture and experience with patients with hip fracture informs our approach to the concept of frailty in hospital, a topic that's of huge importance. The discipline of geriatric medicine has got itself into a complete pickle trying to work out a way of describing itself that doesn't involve talking about older people. And I think that betokens a failure on our part and on everybody's part to recognise that what geriatricians are doing is not about old people. It's about people who are frail. And frailty is the topic that we, as a discipline, have a particular skill in dealing with. And I think it's really important that we understand and own the concept of frailty and look after how it's used by the health service and other people if we're going to protect the frail and elderly patients who we look after. The way that we define frailty is complicated, and there are a number of ways of approaching it. Linda Fried's seminal paper looking at this spiralling interrelationship between nutrition, poor nutrition leading to poor muscle mass, to poor strength, to poor functional abilities, to poor abilities to get food and feed yourself, and a spiral of decline of frailty is a really powerful biological description. And though you can intervene in a number of points in that circle to try and break it, it remains, I think, less useful as a clinical concept than some of the other ways that are available to us. The frailty index is, I think, a concept that is important for us to understand. This is part of the work by Ken Rockwood in Canada, and a beautiful description of a tool that's hugely powerful in its ability to understand our patients. Now, the frailty index is defined like that. I think that's a little bit too complicated, and certainly working as I do with orthopaedic surgeons, we like to keep things quite a lot simpler than that. My way of thinking about the frailty index is, of all the things that I know about my patient, what proportion of them don't work quite right anymore? How does that work? Well, for an orthopaedic surgeon, it's relatively simple. There's only one thing that they know about when they've had a look at this patient's x-ray in the morning meeting without having met the patient. They know that she's got a broken hip. So on a frailty index, from a frailty index perspective, 100% of the things that they're looking at are broken. A frailty index would be 100%. Frailty index of 1. The more holistic orthopaedic surgeon might note that she doesn't have osteoarthritis in her hip. So there's two things he's noticed, and one of them's broken, one of them isn't, so frailty index will go down to 50%. And that's broadly how it works. The Rockwood approach sums that up over dozens of different questions that are potentially could be asked of the patient when you actually see the patient and talk to them and examine them, and the frailty index sums up the figures across all of those. With hip fracture patients, that's something we did in a group of a large number of patients, 178 people, sequential admissions with hip fracture to our unit. And Manju Krishnan collected the 50 pieces of information about each of them from her assessment of those patients and logged that information to look at how it predicted outcome. And unsurprisingly, the people with low degrees of frailty, so a third of patients, a quarter of things, less than a quarter of the questions you ask identified a problem. But in a third of patients, more than 40% of the questions that you asked showed an impairment in patients' abilities and patients' physiology and pathology. And you can see that there's obviously a dramatic difference in outcome in terms of length of stay, and I'll talk about mortality as well. If you're going to test whether a tool is effective, you need to look at the area under the receiver-operator characteristic, which is this graph of sensitivity and specificity. You want something that maximizes your sensitivity and specificity. And obviously, if you toss a coin, you can predict outcome and you'll be right 50% of the time. So that's 50% is not a very good area under the curve to be achieving. If you measure patients' abbreviated mental test score, you can get a much better area under the curve. And the AMT score, the identification of people with cognitive impairment, is a hugely powerful way of predicting outcome for patients with hip fracture. Patients who have dementia or who have cognitive impairment and unrecognised dementia tend to do very, very badly during their time in hospital. But if you build on that and test the frailty index, you really maximise this curve. That curve won't go any higher with any other score that anybody's ever written. There are dozens of papers produced on ways of predicting the outcome after hip fracture. I referee about one a month, and most of them go in the bin. It's very easy to predict outcome, but nobody's going to do more effectively than the frailty index has already done. It would be nice if we could get up to 100% prediction of outcome, but predestination went out in about the 15th century. You do have to remember that the outcome for patients does depend on what we do to them. It's not all predetermined by how frail they are. So 80% of patients' outcome is determined by who they are, and the frailty index really pulls together all of the elements of who these patients are. And that's nicely demonstrated by the data that Manju was collecting on these people. So she asked all of these patients 50 questions, and a third of the questions identified a problem. So it meant that on average a patient presenting with hip fracture, 15 things wrong with them that would be of interest to a geriatrician and interest to the multidisciplinary team who are going to be looking after them. And to give you a sense of what the questions we were asking, there are some questions in terms of their functional abilities, their independence, of pre-existing disease processes that patients might have that would be of relevance to their care in hospital, and a substantial number of questions relating to their psychological and psychiatric background as well. And it's that combination of factors that is brought out. And that's what a comprehensive geriatric assessment is. It's bringing together the information both from your own interaction with the patient and everybody else's interaction with that patient, putting it all together to get a complete picture of everything that's wrong with the patient. That's what comprehensive geriatric assessment will tell you about. And once you've done a comprehensive geriatric assessment, you can calculate people's frailty index, and it'll predict their outcome. It'll give you a better sense of their outcome and a better grasp of what you might or might not need to do for them than any other approach. And that's important that we think about how that might work in clinical practice, because the frailty index is a very powerful tool for predicting outcome, and nothing comes close to it. But should we be using predictions of outcome to determine how we approach the care of individual patients? And I think that's a really important area that we should understand from the history of geriatric medicine. If you go back into the dark ages of prehistoric time, the sicker you got, the more likely you were to die. There was a direct relationship between the two of them. But as health care has developed, there's been a question of whether we can do something to influence the relationship between the acuity of somebody's illness and their chances of surviving. And the intensity and quality of acute care that people are given will clearly have an effect. The problem in geriatric medicine, and the challenge that we as geriatricians have faced over many years, is that age has been used as the marker of frailty, the patient's abilities to cope with acute illness. It's just been used as a shortcut for assessment. And old age has been used not as a way of informing patients' care, but as a way of diverting people away from receiving acute care. When I arrived in Cardiff, the geriatric medical department was in an off-site hospital. We had our own HDU, but we were in a separate hospital from the acute hospital. Reintegration of old age care back into the acute, into medicine has been an enormous step forward, but there's still the potential for patients who are old to be diverted away. And in the morning X-ray meeting, when I'm sitting there with an X-ray in front of the surgeons, they adopt their usual approach to trying to assess a patient's frailty of looking at how old they are. They can't help doing it. And of course it is appropriate to look at patient's age, because if you don't know anything else about a patient, their age will give you a very strong indication of what their outcome is likely to be. And indeed, if you don't plan on going and talking to them before you go to theatre, and that is the practice of some surgeons, you're going to make a decision on the basis of the X-ray and then meet the patient in theatre as the next stage. Age is a powerful way of making a judgment as to what might and should happen to the patient in the absence of any other. But of course, what we need to do is to say that old age is no longer appropriate. We shouldn't be ageist in our attitudes to patients. We should know more about patients, and we should use more information to make decisions. And the concept of frailty should replace age as a powerful indicator. And there is evidence that frailty is better than age as an indicator. Question is how and when and do we do those assessments, and how do we allow them to affect how we look after patients? I'm sure many of you will have seen the Clinical Frailty Scale, again a production from Ken Rockwood's group in Canada, a very simple descriptive scale that allows you to rapidly allocate patients to categories of increasing frailty. It's worth looking at this because it's commonly being used in clinical practice. It's going to become a standard in many clinical areas. And we need to understand what it's telling us and more importantly, what it's not telling us. We know it works. So this work from Jonathan Hewitt in Cardiff, looking at how the clinical frailty scale was able to very powerfully predict the outcome for patients presenting with COVID. It's clear that this score will give you predictions of outcome, and those outcome predictions are more powerful than patient's age of itself. But there is a risk that once you start allocating people to these categories, they will be managed and patient care will be triaged, and patients in the highest categories will be diverted away from appropriate acute care. We know that happened because during the COVID pandemic, one of the hospitals in South Wales published their plan for exactly how they were going to do that, and identifying patients who had a poor clinical frailty scale and using that to inform a decision on that patient's prognosis, and a decision tree that diverted some patients away from the possibility of surgery or potentially even from being admitted to hospital during the height of the first wave of the COVID pandemic. And if you go to the National Hip Fracture Database, you can look at the patterns of care across the country, and you can see that non-operative management, which used to be a really common approach to hip fracture management, is pretty much never happens now in the UK. But there was a spike in non-operative management at the beginning of the COVID pandemic. That was confined to a small number of hospitals at that spike. So this is figures for non-operative rates in a number of hospitals, in all the hospitals around the UK, and you can see that there were a handful of hospitals who didn't operate on 1 in 6, 1 in 5 of their patients at the height of the pandemic. The possibility that decisions about patients' frailty based on a very simplistic assessment like the clinical frailty scale is something that I find personally very worrying, and that there's a real risk that frailist attitudes will develop, that people will be labelled as frail on insufficient evidence, or labelled as frail when the prejudice of the treating doctor, surgeon, clinical team is that this isn't somebody suitable, and frailty might be used as an excuse not to treat them. And I think it's really important that we try and manage how that process might affect our patients in the future. And it does matter, because the electronic frailty index is out there now, a system for identifying from patients' records, their electronic records, whether they may or may not be frail. It's been heavily researched, lots are written about it in the literature, but this is the key phrase that I would raise as a concern about that sort of approach. So there's a 16% increase in mortality when you compare the least frail and the most frail groups of patients using the electronic frailty index. So unlike the full frailty index, that the detailed construct built out of a comprehensive geriatric assessment that I talked about earlier, this electronic labelling system has a pitifully small ability to distinguish the frailest from the most robust of our patients, and there's a real risk that what is an epidemiological tool might be used as a clinical tool to divert some patients away from appropriate care, and some patients inappropriately away from appropriate intensive care for their acute illness. These scoring systems are very powerful. When Ken Rockwood wrote this paper, which shows really powerful and explores in a very strong way the relationship between the acuity of somebody's illness and the extent of their frailty and how that impacts on their outcome, they showed real differences between different groups of patients. But key to that study was this was a group of 1,000 patients who were having their assessment driven by Ken Rockwood himself. This isn't something that can then just be taken and handed to the receptionist in the emergency unit, the triaging nurse in the emergency unit, or as I've seen it in one piece of work, orthopaedic surgeons allocating frailty categorizations to patients and believing that they mean something, even though the evidence behind that demonstrates that actually the surgeons were completely unable to distinguish between the frailty categories, and they couldn't achieve that at all. So rather than this model of how frailty and allocation of frailty categories to patients might impact on their care, we need to think more intelligently about it. We need to be using some sort of measure of frailty to try and categorize our patients, to try and understand them. And a frailty measure, I think, is a powerful piece of equipment. But what we need to be sure is that it's not just being used to identify people who can be diverted away from acute care. It needs to be used to identify the patients who need to receive comprehensive geriatric assessment, because comprehensive geriatric assessment is most impactful for the most frail patients, and it will provide a beautiful complement to the intense acute care that we're all used to, the intensive care, the higher levels of care, the surgical cardiological interventions that are so available. But if you counterbalance those with the complex care driven by CGA and the multidisciplinary team, then we might provide a better balance to the care offered to older people in hospital. Actually, that's probably not the right way to design things. What we really need is the frailty measure is brought into being comprehensive geriatric assessment, and for appropriate groups of patients, and I think mine are one of those groups, you should be measuring frailty as part of your comprehensive geriatric assessment. You give comprehensive geriatric assessment to all of your patients. And it's important that we are cautious about what comprehensive geriatric assessment, what any assessment of patient outcome can tell us about an individual patient's prognosis. We mustn't start believing these very powerful looking papers that tell us that hip fracture care, the outcome of hip fracture care is very predictable. So in this study, which we published in Anesthesia a few years ago, we took the predictions of outcome used from the National Clinical Audit and the predictions from the Nottingham Hip Fracture Score, really very powerful and effective tools in the list of things that are available that can predict hip fracture outcome. And we looked at what they told us about outcome for patients with hip fracture. And if you just look at the group of patients in the black line, so this is about 11% of the patients presenting with hip fracture. These are people with an ASA grade of 4, so they have severe and incapacitating illness. They're people who we're expecting to do poorly. If you look at their outcome and compare them with the dotted line across the bottom of the page, people who are ASA 1 and 2 who are fit and healthy, you can see that mortality for these patients is perhaps 20 times higher for the ASA grade 4 patients. So it's a very powerful predictor of outcome. Except that that's relative mortality. It's a relatively, it's a comparison of relative risk, not absolute risk. And you have to remember now that anaesthetic and surgical care for patients is so good that people don't die during hip fracture surgery anything like the way that they used to. And the risks that you really want to be talking to a patient about are not, oh, you're at 40 times greater risk than your daughter would be in this situation. That doesn't mean anything. What actually is their risk? You need to know people's absolute risk. What's their absolute risk of dying? And how that accumulates over their time in hospital. And the absolute risk of somebody dying on the day of surgery is about 1%. And it is on the next day, and the next day. And for much of their time in hospital, the absolute risk of people dying in this very high risk category is still small. And if you want to show how small it is, then start with the survival curve, because this is actually what people want to be talking to you about, is my chances of coming through this operation. And the chances of any patient, any category of patient, including the moribund coming through surgery, is that 95+% of all patients in all categories come through surgery. So however good your prediction tools are, and these are good prediction tools, they're really not telling you very much. The people in the worst categories of any prediction tools still are very, very likely to survive. And if you take the other approach of saying, oh, they're a high-risk patient, they're a high relative risk patient, and divert them into non-surgical care, they'll die. Without surgery, most people die. So overconfidence in the ability of outcome tools to predict the outcome for an individual patient without an understanding of the absolute risk for individual patients can be a disaster for them. So we must be very careful that these frailty tools that identify people who need the additional help of comprehensive geriatric assessment aren't saying, and they're not well enough to have acute coronary care, to have acute surgical care. That balancing act is something that geriatric medicine has to face in the course of the years ahead of them. So this is my most unfit patient I've ever looked after. No one would have expected him to do as well as he did with surgery. All of our conversations with him were guided by the numbers I've talked about, but the anaesthetist looked very grave when they took him to theatre, and is looking very pleased with himself at the end of it. Patients do really well with hip fracture surgery. We need to make sure that they get offered it. And then a final issue, really, in terms of how we approach orthopaedic surgery, and this relationship of patient frailty to outcome, is this graphic that you'll see in a number of the orthopaedic the geriatric medical journals, talking about how functional abilities, how patient frailty increases with an acute illness. And patient frailty varies with time. People's functional abilities vary with time. And while a minor illness such as an infection might lead to a dip that doesn't impair somebody's ability to manage, with a hip fracture, people drop from being independent to being completely dependent. You can't get out of bed with a broken hip. You are completely dependent after it. So your frailty, your apparent frailty, changes very dramatically, but only temporarily. So we mustn't view frailty as a fixed concept for individual patients. It's not something that could be tattooed onto your patient. It's not something that should be recorded in the notes for posterity and then used to inform future decisions, because it changes. Patients need to be constantly reassessed. Their frailty will change. Our approach when we're looking after our patients with hip fracture is therefore that we don't score our patients' frailty, we're not recording their frailty, and we're not using it to predict outcome. We're providing comprehensive geriatric assessment to all of the patients who come into hospital, so that the input of the geriatrician counterbalances the brilliant care that surgery and anaesthesia can provide for them. And between that, we've managed to rescue the frail end of the population presenting with hip fracture, and it's through that impact of comprehensive geriatric assessment and orthogeriatrics that we've halved mortality following hip fracture in the course of the last 15 years. What we do need to do, in addition to providing orthogeriatric care to those patients, though, is to teach the surgeons and the anaesthetists about some of the aspects of how that might impact on their care of patients. And while you can see that this patient takes a sudden dive in their frailty, in their abilities at the time of their hip fracture, the extent of that dive depends on how well that hip fracture is looked after. And one of the things that we've tried to build into our protocols for the management of patients in the perioperative period, a topic for another talk, is that the high quality preoperative management, particularly of blood management and bleeding management, and post-operative management to make sure that people are have proper pain control, have proper fluid and blood resuscitation and management in the immediate post-operative period, are fundamental to reducing the impact of the injury on them. So while patients coming in with many diseases have an unpredictable impact, and COVID, you can have little or no symptoms, or you can be crushingly ill from the onset. For hip fracture, we know that everybody takes a dip down in their abilities, but how deep they fall depends on how far we let their acute illness take them. And if surgeons and anaesthetists understand the complexity of the management of the frail older patient, and particularly pay attention to issues such as blood transfusion, the perioperative care of fluid management, of painkillers, they can minimise the drop in function that patients have, and leave less work for the rest of us, the rest of the multidisciplinary team, to do to get people back to as close to previous abilities as possible.